I'm Istvan, and I'm here in Regeneration TV with Professor Dr. Tiziano Testori, who's one of the forefathers of the sinus. And so our topic in the next couple of minutes is going to be the sinus. You have just given a fantastic presentation, an overview of 30 years about the sinus. And if you could summarize what you learned in 30 years.
First of all, I want to thank you, Istvan, for the kind invitation and my best compliment for the venue. It's unbelievable.
Thank you.
We can breathe culture here in Budapest, and it's a wonderful place. It's my first time in Budapest, and I really enjoy it, and I like very much your country. So what I learned over the years, I learned that I should be aligned on the patient outcomes, meaning that when I see a patient that is dangerous, my first thought that crosses my mind, can I provide teeth to the patient in the less invasive way? Can I minimize the trauma for the patient? Can I minimize the post-op? Can I make the surgery easier? Because the easier the surgery, the less complex is the surgery, the less complication you have down the road. And so I learned over the years that if you approach any surgical procedure, there are three major factors to be known. And as you said this morning, first of all, knowing anatomy, and knowing exactly your hands in which layer are they working. Second, pick up the surgical procedure according to your learning phase, and so you have to have a score, as the one they published, sinus lift score evaluation, difficulty score evaluation, in order to differentiate the complexity of the case, because in your early learning phase, you might think that the sinus lifts are all the same. No, and to understand that, I'm doing an analogy. Are we going to do a root canal of the central incisor, or are we going to do a root canal of the second molar with calcified patient, with the patient that is not opening the mouth, with the big tongue, not very nice to us, that all of a sudden you get into trouble? So I think classify the patient and understanding the complexity of the before the surgery, and then learn before doing any kind of procedure which are the complications. And if you are not able to deal with complications, to have at least, as I said at the beginning of my lecture, a friend in the other field, ear, nose, and throat specialist, an ENT guy that can help you in make a diagnosis, pre-op diagnosis of the sinus, and then eventually help you in solving the problem post-op, in case of post-op complication, that they need to have a multi-disciplinary approach. And lately, I understood that we have to think completely differently in a patient fully edentulous or lacking teeth, premolars and molars, of only one tooth or two teeth in between natural teeth. Usually dentists, they come up and they show a little radiograph on a panorex, and they are focusing only into the height of the bone. And this is a very short-sighted vision. So we know that implant dentistry is a top-down treatment. You should start envisioning the prosthetics, and with digital dentistry and with the prosthetic procedure, we can do that. But definitely the prosthetic plans should precede the surgical intervention. Usually in the real world, they put the implants, and then all of a sudden, let's restore them. That's not the case of top-down treatment. as you were showing this morning. Short implant, yes, they can be successful. But what about the crown? You can clean the crown. How ugly is the crown? These are important factors that we should take into consideration.
So basically the sinus is in an area which is a borderline between oral surgery and dentistry and medicine and
Sure.
ENT. So you're also saying that it's important to find a colleague, an ENT surgeon, who understands what you're doing, and you can always collaborate with. They can maybe work on your pathology to make it possible that you're going to do sinus grafting, and also when there's a complication, you may be able to work with somebody together. So do you have one specific person or several clinicians you work together?
We have a network of ENTs in Italy, and I'm suggesting you to do the same here in Hungary. So we have a network of ENT who are knowledgeable in functional endoscopic sinus surgery. You know why? Because even among the ENTs, there is a lot of discrepancies, a lot of differences in knowledge. Of approaches. And you know, historically, and I'm telling you that in my early phase of my career, in '81, I graduated as a medical doctor. I should have been an ENT because my uncle was the chief of the department at the General Hospital in Como, near Milano, so I was following him, but we were not getting along very well. So after a while, I quit from ENT and I went into dentistry. So I did in my early phase of my career many Caldwell-Luck approach. And you know, historically, the sinus is like amalgam 1 restoration. The stupid ENT does the sinus because it's an easy surgery. It's not like doing cancer in the throat
or the inner ear.
Or the inner ear with a microscope. But all of a sudden, from Graz in Austria, the group of Messenklinger, Stamberger, they invented the functional endoscopic sinus surgery, a subspecialty within the ENT guys, and they understood that there is a niche. You know, in Italy we have ENT that they became rich because of the dentist, helping dentists in solving the post-op problem and knowing exactly what we do. And so I think to have a collaboration with somebody who is knowledgeable in this field, because otherwise a normal ENT will not be aware of what we do, because we don't speak to each other.
Did you ever have a patient who was sent to you, an ENT, for example, told the patient that there is some type of tumor in the sinus, and it was a sinus graft, because they had no idea what it was?
Yes. If the ENT is not knowledgeable in what we do, it's a big problem. Because, you know, I don't know here in Hungary, but in Italy, they see ENT guys like doctors, and we see us as dentists.
Right.
So when somebody gets an opinion from a doctor, it's very difficult to tell to the patient, wait a minute, he doesn't know anything about this. I will send you to see another doctor who is knowledgeable. So you gotta fight with the ENT until you find somebody who is knowledgeable, is willing to collaborate. Otherwise, it will be a big mess for you and your patient, because there are controversial opinions, and usually they are not very right because they do not know. And like in they speak without knowing. That's the most dramatic situation for a patient.
So the last couple of minutes I would touch upon two topics. The first topic, both of them would be my complication with sinuses. Number one, the perforation and the different size of perforations, locations of perforations. And I hear that more and more that that clinicians, they have sometimes a huge perforation and they do like a salvaging type of procedure. I hear about techniques like parachute, when they do like a huge membrane somehow, Loma Linda pouch, and things like that. What is your opinion if you have a perforation of more than 10, 20 minutes, like a huge perforation? What do you think? Would you manage it, or would you recommend to maybe abandon the procedure?
Let's say that we publish an article with Steve Wallace, 20 cases with histological evidence on each case and radiographical CAT scan evidence of success with the Loma Linda pouch technique. But during courses, we remove that part because it should be very well understood. This technique is very technique sensitive. It can be a biological bomb that you have inside the sinus. So
can you explain a little bit about the Loma Linda pouch?
The Loma Linda pouch technique that was invented by Prof back in Loma Linda.
He's a friend of mine.
A friend of yours?
Yeah. We were students together in Loma Linda.
You have a big perforation, you scrape all the membrane away from the sinus wall, and you do like a pouch in your trouser. You reflect inside the sinus, and you fix the membrane on the outside wall of the sinus, and then you create a little pouch inside the sinus. Why it works? Because we know from biology that the epithelium will be healed in, let's say, 6 to 8 weeks. And by the time you have resorption of the membrane, fast resorption of the membrane, you have reconstitution of the sinus membrane. And your graft will be confined with this technique. But if the graft is suboptimal handled, a little bit of contamination, it will be a biological disaster, because antibiotics, they cannot really get into the situation, get into the site, because you delay vascularity, you delay the vessels, because you are interposing from the bone, comes the vessel and membrane. It's a completely different situation compared to your regeneration technique. So the Loma Linda technique, pouch technique, can work, but you should understand the biology behind it and should be handled in a very clean as possible situation. I think it's better to abort the technique and re-entry after 2 months.
Thank you. And you were mentioning about bacterial contamination of a graft. In case, the worst case happens, that let's say there is a graft infection and maybe a postoperative sinusitis, the two together, what do you recommend for the average clinician who is doing maybe a couple of sinus grafts a year?
Okay, we wrote an algorithm that is published in the literature and is published in different chapters that we wrote on the new book of Myron Navis and Omli Wang regarding complication. There is the algorithm that calls for a differentiation between a sinus graft infection of a true sinusitis that is less common. Let's say we give a chance to the graft to recuperate, giving a shot of antibiotics, another second regimen of antibiotics. But if the situation does not get any better, you don't have the resolution of the symptomatology, you got to do something from the surgical point of view, remove partially or remove total the graft, as in the paper that you wrote in 2012, partial removal of the graft without placing the implant, but it's very technique sensitive, very empirical. And I think in case of infection, follow an algorithm, follow a protocol, and rely upon somebody who can help you. But the advice that I can give to you, do not wait long first, because you can have a complication that you don't even imagine. I see in my career patient losing the sight, the vision because of infected sinus graft. I saw brain abscesses, and one is recently published in the Esposito journal of a patient that has stayed in a hospital, hospitalized for 2 months with a craniotomy to drain a brain abscess to a transclavicular sinus lift. So you should solve the problem as soon as possible until you have complete resolution of all the symptoms. You know that the sinus is close to the orbit, and you can have kind of complication that normal dentists, they are unaware of this complication and could be a disaster for the patient.
I think we can tell this message to the clinicians that despite that the sinus is considered to be very, very predictable, and it is, and many of the colleagues think that it's very, very easy, and a simple sinus may be very easy, but they should take it very seriously because it can result in medical consequences. So patients should be followed up, prepared very well, surgery should be done very well, it should be followed up very well, and in a case if there's a problem, you may have to consult also with the ENT, and maybe the joint effort.
You summarize everything that should be done. This is our clinical recommendations.
And one more question. How do you see the future of the classical sinus graft?
The future of the sinus graft will be the use, I do think, of biomaterial that they become bone of the patient, so they react to problems like bone of the patients, because I'm a little bit skeptical of biomaterial that are not fully resorbable. That's my idea.
Your idea.
Based on some kind of experience and then a publication that has been accepted, that when you have minimal quantity of bone to start with, and then graft get infected, it's more difficult to get rid of the infection from a peri-implantitis if you have no resorbable, as Sandro was pointing out this morning.
What do you think our approach is? We're going to publish now long term that where the implant was, we used biomaterials, but where the implant was, we used an autogenous sandwich in the middle for this specific purpose.
Yes,
and it seems to work now pretty well.
That's the sandwich technique that with Omni Wang, we teach the sandwich technique, first layer of autogenous bone to have a buffer zone of autogenous bone of the patient, and then biomaterials on top to slow down the resorption and to keep the volume. But that's the approach that has a sound biological, scientific fundamental.
And one last thing. How do you see your cases long term who had maybe 1 or 2 millimeters of bone in the sinus and you grafted maybe 20 years ago? How do you see the implant survival?
The implant survives as long as the patient is on a full maintenance program. They're fine. They're fine. And you know, we found a way to get patient coming for recalls. We make a protection plan, kind of warranty to the patient, and the patient is insured for any biological problem
as long?
Up to 10 years if it comes to a scheduled maintenance program. So it's like when you buy a car and
you change the oil or not.
And you have your car serviced at the official dealer, Audi dealer or whatever. All the pieces and bolts are covered. You pay only for the labor. So we tell to the patient, in the same situation, if you follow the protocol and we make a contract, you are covered from all the biological costs. But you have to come to the office the first year every 3 months. If you are very clean, every 4 months. If you are super clean, at the third year every 6 months. Why? Because I can intercept mucositis then don't go into peri-implantitis.
That's great.
Yeah.
Professor Testori, thank you so much for
Thank
your
you,
beautiful
Istvan.
presentation
Thank
and
you
for
so
this
much.
interview.
That's
Thank you
been a
very
pleasure.
much. Thank you.
Thank you.
Thank you. Goodbye.